Hello everyone out there. Thank you for joining us for tonight's event. I'm Emily. I'm one of the event hosts here at Powell's. Before we begin, I just want to give you a quick reminder to check out our lineup of upcoming virtual events online at powells.com. We're looking forward to welcoming Tom Hartman tomorrow and Vanessa Vilsaca on the day after, among others. Please remember to follow us on Twitter, Facebook, and Instagram. As well, if you haven't already done so, you may sign up for our weekly events email at powells.com. Tonight, we're honored to welcome Ezekiel Emanuel in conversation with Jonathan Cohn. Ezekiel Emanuel is the Vice Provost for Global Initiatives, Diane and Robert Levy University Professor, and Co-Director of the Healthcare Transformation Institute at the University of Pennsylvania. He has written Reinventing American Healthcare and Prescription for the Future, among other books. Jonathan Cohn is a Senior National Correspondent at HuffPost and has been covering social welfare with a focus on healthcare for 20 years. He's the author of the award-winning Sick, The Untold Story of America's Healthcare Crisis, and People Who Pay the Price. His new book, The 10-Year War, will be out early next year. The US spends more than any other nation, nearly $4 trillion on healthcare. Yet for all that expense, the US is not ranked #1. It's not even close. In which country has the world's best healthcare? Manual profiles 11 of the world's healthcare systems in pursuit of the best, or at least where excellence can be found. So this event also includes a Q&A. If you look at the bottom of your screen, there's a Q&A box. If you don't see it, try clicking that More button. Please go ahead and ask any questions you may have for the author in there. As well, if there's a question that you also want to know the answer to, you can upvote questions. And perhaps most importantly, please consider supporting Ezekiel Emanuel and Powell's by purchasing a copy of Which Country Has the World's Best Healthcare System. I'll be including a link to buy the book in the chat this evening. Now, please welcome Ezekiel Emanuel and Jonathan Cohn.
Thank you very much. Thanks for that introduction. I am very excited to be here. First of all, I'm honored to be here at a Powell's event. I'm wearing my Powell's t-shirt. Powell's bookstore is a sort of nationally recognized landmark, so I'm really quite honored to be part of this. I'm also honored to be here with Zeke Emanuel. Dr. Emanuel, if you don't know him, but around Washington and in policy circles, he is known as Zeke, which is, of course, you know, the kind of honor reserved for people like Beyonce and Cher, and that's roughly his sort of equivalent place in the world of health policy. In all seriousness, 3 quick things to tell you about Zeke, and we'll get into the book. Number 1, he's the only person I've ever met who went to Harvard Medical School, and it was too easy for him. So he decided, completing his 3rd year, to go get a doctorate in political philosophy at Harvard also. The second thing is, you may know he is a member of the Emanuel family. There's a reputation for being very outspoken. While Zeke does not use so much the colorful language of some of his brothers, he is definitely someone who likes to express his opinion, which makes him a very interesting person to talk to about health policy. And the last thing, which not everybody knows about him, but if you ask around Washington, you ask around intellectual, the academy, people will tell you he's an incredibly generous person, somebody who cares deeply about helping other people, whether it's on a personal level, just helping somebody with a medical problem, or trying to fix the world's problems. So you might say that I always like to say Zeke has a big brain, a big mouth, and a very, very big heart. And that is very much the spirit of this book that he has put together. Which country has the world's best healthcare? And a very timely book right now. Obviously, we're in the middle of a pandemic, and that's something I hope we can talk about in a few minutes. But before we get to that, you decided to put together a book looking at all the world's healthcare system. What sparked this interest? I mean, you've been doing health policy for a long time. Why now kind of look into this?
I was very resistant to doing this book. I really didn't want to do this book. There are many things which are good for me that I don't want to do. But I used to go around when I finished working in the White House and previous books, and people would always say, well, which country has the world's best healthcare system? And I would sort of poo-poo that question and say, well, it's not really a good question. There are lots of different rankings and they don't agree. I would also say, you know, you can't just take a healthcare system from some other country and ship it over and plop it down to the United States, so why bother? And then finally, you know, after you get the question enough, you sort of say, all right, I'll do it. And so that was what I did. What could we learn from other healthcare systems that would be helpful? And I am here to attest that my questioners were right and I was wrong. Yes, ranking them is probably not a good idea by strict numerical rankings, but looking at them and what they have to offer and how they operate is a very good idea, and it can give you a lot of lessons for our healthcare system as well as other healthcare systems. I know that some of the countries I reviewed, they really like the book because it helps them think about how they should reform their own system.
That's interesting. Well, one of the reasons this is, we're at this moment and talking about this is we do seem to be starting another conversation like we have in this country every 15 or so years about how to fix the healthcare system. You were obviously an inside player in the last effort that led to the Affordable Care Act. We have a different healthcare system today than we did 10, 15 years ago because of that, and something else we can talk about in a few minutes. But whenever this debate comes up and we start talking about other countries, you hear two very different stories from the two political ends of the political spectrum, right? So there's the story on the right that, oh my God, if you have, a universal healthcare system, everyone's going to wait for treatment and they won't have any innovation. There'll be sort of, impersonal, terrible care. On the left, you will hear this, you will hear a version of, it's great, it's perfect, everything's free, everything's quick. Let's deal with them separately. Let's start with the argument from the right. Where's the truth? Where's the lie? What did you find looking at systems? Are people queuing up and are they, pulling the plug on grandma and all that stuff?
Well, there are plenty of systems that have universal health care coverage, that there are no waiting lines. You can choose your own doctor, and there's plenty of innovation, and they're certainly at the cutting edge. And the favorite, or what tends to be a favorite among conservatives, Switzerland is one of those systems. They have universal coverage, 99.9% of people, in part because if you don't sign up, they sign you up, and the penalties are extreme for not signing up. Similarly, the Netherlands and Germany are two countries where you pay a tax. The government then pays private insurance. You select which insurance company you want. They pay private insurance, and you get coverage through a private insurance company. And they also get universal coverage because if you don't enroll, they enroll you, and they take the money directly out of your taxes. Typically, there's also a small premium that you have to pay. So this idea that you have universal coverage, you don't get choice of doctor, you have long lines, totally false. There are countries that don't have those problems at all and have 99.9% coverage. And by the way, there are countries that have universal coverage and do have some lines and nevertheless have extremely good care, and the lines are pretty marginal. So this sort of caricature is definitely wrong, and it just built up around one or two models that people think they know something about, which is wrong.
Well, let me follow up with that. So you said there are countries where they have some weights, but there's still good outcomes. What's an example of one of those countries? I think I might know which ones you're talking about, but tell our readers, tell your readers here.
Well, Norway is one of those countries where you pay taxes. Norway pays to regional health authorities for hospital care and specialist care, and they pay to the municipalities who then pay the primary care doctor. There are some lines in Norway, but you got pretty outstanding care. You can choose your primary care doctor. On the other hand, when you do go to the hospital or you need specialty care, your choice is much more restricted. There are other countries where you do have choice of specialists. France is one of them. Germany's another one of them. Germany's a remarkable case because you can go to 10 doctors in a day, and the system will let you go to 10. You want to go to 10 orthopedists to have your knee evaluated, you can go to 10 orthopedists and you pay nothing.
So if I had, I'm trying to imagine your standard economist hearing that story you just told about Germany, and I know there's other countries like that as well, where you can literally see 10 doctors in a day. I mean, we'll leave aside the question of why you'd want to see 10 doctors in a day, but I get your point. I mean, it just sounds like it's got to cost, you're going to explode costs that way. There's no controls. And yet I know Germany spends less relative to GDP. All these countries spend. So how does a country like Germany hold down costs without limiting demand? or supply?
Well, first of all, let's just say that there are almost every country, not every country, Switzerland and France are two examples which are different, but almost every country has a budget. And they establish a budget, and that budget limits how much they're going to spend on healthcare. So Germany being an example, they collect money through taxes that goes to the government. The government then reallocates out to what are called sickness funds, basically insurance companies. When you select an insurance company A or sickness fund A, they pay a certain amount, and then the company has a small premium for you. But there's a budget, and you can't exceed the budget. And it turns out that if doctors submit too many procedures, for example, or too many office visits, the amount that they get paid goes down. And there's a sort of a rheostat there that actually pretty closely regulates how often or how much doctors can charge. Taiwan has the same thing. Taiwan has unlimited choice. People who are in Taiwan love it. You can go in and you can actually order your own MRI. But in Taiwan, if doctors churn out too many visits and they're more than the amount of money that the government has for it, they get paid, say, 90 cents on the dollar rather than 100 cents. And so countries that they have a lot of choice, you can go to doctors, they cap the total amount of spending, and that is how they control healthcare costs. So they're not spending like we are, nearly 18% of GDP. The exceptions to that are Switzerland, where, interestingly, everyone likes their choice, everyone likes the system, but everyone complains about how expensive it is and worries that the system might run off the rails because it's so expensive. They don't have a budget. And similarly in France, because of the kind of hybrid public-private, there's really no budget. And both of those places have very high costs relative to other countries.
Relative to other countries, less than the US still. How much?
Everyone is substantially less than the U.S. We are a pretty substantial outlier here.
And is it clear that, I mean, there's this very famous saying, paper by the late Uwe Reinhardt, used to teach at Princeton, who sort of a dean of, well, one of the deans of healthcare economics, who had this expression that it's the price is stupid. That it was just, that, and I know he talked a lot about physician salaries, right? That we pay our physicians a lot more. I always found this to be a kind of tough nut to crack because it's clear that our physicians make a lot of money. It's less clear to me they make a lot of money relative, say, to lawyers in this country. I mean, our whole income scale is all over the place. So, I mean, how much of a factor in these other countries is physician pay in terms of, how they're able to save money? And that kind of gets us into the question of how do you get there from here in a country like the US where we're starting at a very high level?
Yeah, that's a very complicated question. I did write about this. Some of it's prices, but not all of it. And yes, some of it is physician salary. Some of it's also we pay a lot of money for certain procedures like MRIs relative to the rest of the world where that procedure is much lower paid. But compensating for the high cost per doctor, we also have a relatively few number of doctors per population compared to, say, Germany. Germany has substantially more doctors per population than we do. It is true each one is paid less, but the differential when you take the number of doctors times the pay, the differential between us and Germany is not that large. So you have to look both at how much we pay and which services we have very high volumes of. And we tend to have high volumes of those services that we overpay. And during this moment of COVID, we've learned, because the hospitals have told us loud and clear, they make all their money on elective procedures. Guess what? Elective procedures are something we overpay and we pay too much for. And so they will do a lot of them because the margins are quite high on those elective procedures. There are other things that we pay too little on, and primary care is one of those. There are other countries where primary care doctors, interestingly, make a lot more than in the United States. Canada and Britain turn out to be two of those countries.
So that is interesting because, it's funny, so I live in Michigan, as you know.
Yeah.
I'm about an hour from the Canadian border. A lot, pre-COVID days, pre-9/11 especially, even more than that, when it was real easy to go across the border. I mean, you could go get your drugs right across the border. Just hop on, drive the bridge or the tunnel. And, there is this sort of reputation that Canadian healthcare has. Of course, Canada being so close, it's something we a lot, especially in the North, we have exposure to. And you hear, oh, the waiting lines, again, the same waiting lines, and yet their pharmaceuticals are cheaper. And I was going to ask you, I mean, it seems like maybe on specialty care, sometimes people feel like they can get more options here, but on primary care, are they actually better than us, or is it all the same? I mean, I don't know. What's a good US-Canada comparison?
I think, Jonathan, that gets to the heart of the book, which is there's not one metric. Is Canada better than the US? It depends what is important to you. If you ask, well, I would like it to be free at the point of service. When I need to see the doctor or go to the hospital, I want it to be zero. I don't want to have this copay, this deductible, and I don't know what they are. Canada's way better than we are when it comes to that. When you need service, zero pay. On the other hand, through a quirk of history, Canada has comprehensive benefits, but doesn't cover drugs. And most Americans don't realize this. It's not part of the package they have. Some provinces cover drugs. Employers often cover drugs for their workers, but it's not part of the basic package. So in that sense, the United States, despite our high cost of drugs, may be slightly better for many people where drugs are covered. So it really depends upon what metric you're looking at. Do you want to have universal choice of doctors? Well, we know that we have a lot of narrow networks, that people's ability to go to any doctor can be highly restricted. Turns out many other countries, the free choice of doctors is much more extensive than it is here in the United States. Germany, Switzerland are examples. France is an example of that. The Netherlands for primary care, Norway for primary care, free choice of doctor. In Germany, you can go to any doctor, any hospital, anywhere in the country. No problem, right? We don't have that. So we need to be careful about the metric we're looking at and which ones are important to us. And I think once we do that, we learn that our system, it's not very good at most of the things we actually deeply care about. And our perception of other systems is very wrong.
So one thing you mentioned earlier was about this budget. And I think that is part of the secret sauce of most of these places, as you said. And that's true whether you have a country like the Netherlands, which is mostly through private insurance, or Norway, or a single payer like you have in some others. When I talk to what I would say the more sophisticated critics of those systems, they always land on innovation. They always say, hey, you're limiting the budget, and you're going to see, and sometimes they make this very specifically in the context of prescription drugs. They're like, if the government's sort of setting the prices for drugs, there will be less innovation. Sometimes they expand it out to even beyond just the entire healthcare system. And the smarter ones, they can go a couple rounds on this, right? And you'll say, they'll say, and, even to the extent on drugs, for example, they'll say they all make their money on the US market where they can charge whatever they want. And if the US were to adopt that kind of drug pricing, we would see less innovation. And as they would put it, they say it's all well and good to worry about, we get these stories that people don't have healthcare today, and that's terrible. But what if we miss out on the great cure for some kind of cancer 10 years from now? I'll think of all the lives we will lose then. This is, your area here. Talk to me about this. I mean, how real is the innovation argument?
Well, in this book, I point out that I do think the United States leads the world in innovation, along with the Netherlands, but we don't look at innovation of drugs. We look at innovation in payment, innovation of how care is delivered. And because our system, in some sense, is so screwed up, we are trying more things than other countries in terms of how we pay doctors, moving to capitation, moving to bundled payments. And we are trying to deliver care in different ways, especially for patients with chronic illness. I would say that we, again, along with the Netherlands, are leading the world. If you look at innovation around drugs, the first thing I always like to emphasize is we need to be really, really careful about what we mean by innovation. Because there are plenty of drugs that are new, that might even be patented, that are, will qualify as a new moiety from the FDA, and they're no innovation at all. They don't improve care, they don't prolong life, they're not cheaper. I'm an oncologist, as you mentioned. There are some new anti-nausea medications that have been approved, and they've been approved by being no worse than what's on the market. So what we call non-inferiority. They're not better, they're just no worse because the stuff that's on the market is pretty damn good, right? And they charge twice as much as what's on the market. That's not an innovation. Where's the innovation? It's just as good. That's what the research said. It's no better. And it's twice as expensive. Would the world be worse if that drug didn't exist? No, the world would not be worse. And one of the things we end up with is because we pay so much for certain drugs, we end up with a lot of drugs in that area, which may or may not be real breakthroughs. You know, I'm an oncologist, and lots of people tout, well, you know, we're doing great in oncology, and we are at the top end of the world in many cancers. We're not the best in every cancer. Breast cancer is the place where we are the best, but there are lots of cases where we're up there, but we're not necessarily the best. But there are plenty of cancer drugs, you know, prolong life, 3 weeks, 4 weeks, 7 weeks, at $10,000 a month or $120,000 a year. You have to ask yourself, is that really worth it? Because we're willing to pay so much for cancer drugs, we have, you know, 600 and some odd drugs in human research trials. Because we're not willing to pay so much for antibiotics, there are only 40 antibiotics in development in human trial. That doesn't seem like a good distribution. So there's a lot of perverse incentives in that innovation too. And I don't think we can just blow the horn for innovation. We're the most innovative people. There are plenty of other innovations that happen in other countries. And by the way, the difference between innovation here and when it gets to other countries, often zero. And often the time of when a drug is introduced into different countries is determined more by the drug company than it is by the regulation or by the pricing. You'd be hard pressed to go to, say, Australia and find a long list of drugs that Australians don't have, and they're among the best negotiators on drug prices in the world.
We're in the middle of this pandemic now, obviously, and you've been incredibly busy researching and writing about it. What are you seeing from abroad in terms of countries who you feel like have really gotten a handle on this, and you draw that and you link their success, at least in part, to the design of their healthcare system?
Well, I think, first of all, I think that for the countries that have done really well, a large part of it is about leadership and about implementing public health measures in a consistent manner, and really following the public health playbook that the CDC and others developed over many decades. And what we have failed to do singularly is follow that public health
It's
playbook.
our playbook, and we're not following it.
And part of that playbook is create a message, stick to the message, reiterate the message, educate the public. But I do single out Taiwan. I think of all the countries in the world, Taiwan is a standout. I say this because it could have been a disaster. Taiwan sits less than 100 miles off the coast of China. They have extensive trade relationships. 1 million Taiwanese worked in China, lots of connections via airplane, and yet didn't turn into a disaster. I haven't looked recently, but you know, as of a few weeks ago, they had fewer than 500 cases and 7 deaths or something outrageously small like that. Why did they succeed? Well, they succeeded first because they were very suspicious of the Chinese, and they had been through SARS, and they were very, very careful that if something evolved, they couldn't trust what the Chinese were going to say, and they were going to protect themselves. Second, they had this health card, and this health card has basic information. So when you go to the doctor swipes the health card. They know why you're going to the doctor. They then know when you leave, the doctor swipes it, what the charges are, so that they have near real-time information about why people are seeing the doctor and what the doctors are doing for it. So they know if there's a big burst in respiratory illnesses and shortness of breath and coughs like COVID would present. But they also use that information in the health card to cross it with their immigration and customs information so that they could identify people who had been to China, get them tested, get them isolated very rapidly and early on. This is the kind of case of where health information combined with other information can be extremely useful. And they were able to, therefore, contain the spread of the virus quite rapidly. And as you pointed out to me, they also have this face mask culture. Much of the Far East has a face mask culture: Korea, Japan, China, Taiwan, and that turns out was very, very critical to preventing spread. But if I had to identify one thing, so how might we learn from Taiwan? Well, what if we actually had a card? If you go to the best insurance companies, the big ones with a lot of money to burn, they can't tell you what services people are using until 60 or 90 days after they've been to the doctor. That's not real time. That's not actionable information. We need a card like that that'll give us near real-time information about what services are being used, how frequently people are having respiratory symptoms or some other symptoms. And that, I think, would be quite useful. Forget identifying things. You could tell the doctor and you have to have some trust that it's not going to be abused, it's not going to be commercialized and other things. And I think that would be a big plus to our system. Learn from the Taiwanese about this.
One of the themes in the book, I know this is true of Taiwan and a couple of the other countries, is they didn't just snap less true of Taiwan, but they didn't just snap their fingers and overnight go from this one system over here to another system over there. It felt like there was this constant tinkering. And I think that might surprise some people. Am I right that in general, it's more evolution than revolution? I don't believe I just said that, but there you go. I mean, it feels like they kind of moved along.
Yes, and I would say that one of the things that is the case is there are often fits and starts, just like in the United States. You establish a system, then deficiencies come, and then you revise it. So take Switzerland. By 1960, 80% of the population was covered, but it took till in the 2000s to get full universal coverage. And so I think that's quite a common story. Australia is the only example where they put into place a universal coverage system. Then the conservatives came in, they rolled it back. And because they rolled it back, the voters voted them out. And 4 years later, they were back at a universal coverage system. And once you have that, besides that one episode in Canada, you never roll it back. People expect to get healthcare. It is true that around the world, though, you are seeing I would say, a slow move towards more private care, mostly because the burdens on government are extremely high from the budget demands from healthcare, and they're trying to figure out how to make it all work. And having things done in the private sector is one of the ways. So France, for example, they have extensive coverage, but they have very high copays. And one of the consequences is 95% of the country has supplemental private insurance to pay for what the public system doesn't cover in terms of copays and some choice and things like that. That kind of hybrid model you're seeing more and more of. Or the Dutch and the Germans, that they have private sickness funds to provide the coverage, even though the government collects the money and pays most of the premium for people. So,
yeah. Well, you were part of the effort to write the Affordable Care Act, which is the system we have now. And as I said earlier, we are now starting another debate about what to do next. I guess to some extent, we've been in that debate for a while. I'm curious, based on what you learned in your research for this book, tell me something that, looking back, you think, yeah, we got that right. This was a good call. This was a good idea. I see that we were moving in the right direction. And is there anything where you look and say, now if I could do it all over again, I might push a little more for something different along this dimension? So a kind of two lessons from.
Well, I would say on the second's a lot easier to do because I'm very self-critical about what we did. One of the problems that we did is we made the system more complex. We had Medicaid, we had Medicare, then Senator Kennedy and President Clinton put in CHIP to cover children who were falling between the cracks. Their parents worked, but they didn't have coverage for the kids. So that's already complicated, rather than just add them into Medicaid or something. And then we expanded Medicaid, and then we added insurance exchanges. And by the way, the eligibility for Medicaid and the eligibility for insurance exchange is not the same eligibility, right? And the way you pick the insurance, it's like, and you know, the exchanges, we have had all these fights about the exchanges. 15 million people, 5% of the population. We're not talking about something which has got 30% of the population. So I think that's an added complication to the system that is not taken off, and I think is a real problem. And we do, I think, have an incredibly complicated system, and we made it more complicated with the Affordable Care Act rather than simplified it. One consequence is that, as I mentioned at the start of this conversation, Jonathan, one of the great advantages of almost every other system is they do get to universal coverage. And one of the ways they get to universal coverage is what's called auto enrollment. You don't choose, we're going to assign you to an insurance company, or you're in the system whether you've chosen it or not. We don't have that, and it's very hard for us to get that in the current, you know, patchwork system we have that has employers, Medicare, Medicaid, CHIP, the exchanges, the VA system, the TRICARE, and on and on. And I think that's a real mistake. So I would say that one of the imperatives for the next administration that wants to get to universal coverage is we actually have to simplify the system. It'll reduce administrative costs. It'll actually make it easier for people to get coverage. And so it'll be a lot easier to get higher coverage numbers by simplifying the system. And I think that's a very, very important lesson. I think the other important lesson, and here is what I would say, one of the really gems and good things we did, was to get rid of copays for certain services like you know, prevention. So your cancer screening tests, your immunizations, your wellness visit at the start of the year. I think that was brilliant, and I think we should go way further on that. So my suggestion is all primary care visits, no copay, no deductible. All generic drugs, no copay, no deductible. We should incentivize those parts of the system which are quite efficient and quite important by having no deductibles and no copays. So patients will learn, you know, I got to go to my PCP. Who's my PCP? And I got to go to my PCP. And I think that would, expanding that, it was a brilliant innovation that was put into the Affordable Care Act. I think it's done remarkably well in terms of allowing people to get preventative tests. But now we need to learn that lesson and put it on steroids, as you will, if I can mix the metaphors.
You can. Well, it's interesting to say that because, I mean, there was a real, you remember, I'm sure, there was a real push 10, 15 years ago among economists in particular. There was a real belief that, and it seems strange to say this now, but there, and I say this as someone who wrote the stories and I think bought into it. And yeah, I understand the logic that the problem with American healthcare was it needed to be more expensive at the point of service. We needed to give people higher cost sharing so they wouldn't soak up so much. But do you feel like you've learned that you've come to the conclusion that no, that was wrong, that actually we need to make it cheaper at the point of service, not more expensive at the point? And by that, I mean, you shouldn't have to pay out, you know, point of service is policy long talk for everybody of having a high copay.
Yeah. I think for the things we want people to consume, like primary care, we should make it free. And we should increase for more discretionary and elective items. And I think that's the kind of ratio you want. This sort of across the board, no copays, which they have in Canada and other places, and our high deductible plans. I think those extremes are wrong. What is the essential elements, and we should make those copay zero. And I think, you know, elective procedures, discretionary items, MRI tests, probably, you know, we should have a suitably high copay for. So I think that's where we need to go. And one of the reasons I think we make this problem over copays is we think a lot of the choice is discretionary on the public. You know, most of what people get is decided by doctors. So varying the copay, yes, it'll affect how much people utilize, but what it does is it makes them resistant to use the medical system when they need the medical system. And we have a lot of good data about that. And it seems to me that's not the kind of incentive structure we want to create. We want them to use the right part of the system. And that I think we can do. And we
What
should
ab-
incentivize doctors differently about what services they order for patients and what tests they order and how they refer patients and which hospitals they refer them to. That would be much more effective, it seems to me.
to get back to the budget question, again, I keep coming back to that because I think that's such an important part of what these countries do to hold down costs. Would you like to see some kind of version of that in the United States? And having been on the inside, does it seem politically feasible to get a global budget? I mean, Bill Clinton, people forget, tried to do healthcare, and they had a global budget cap in their plan originally. And I think that was one of the reasons it didn't pass, was there was a lot of opposition to it. So, I mean, would you like to see something like that here now? And could we do something like that here?
So I think I'll take the second part. I don't think we could do it, partially because we have private insurance with Medicare, Medicaid. We have all these moving parts that I think make a global budget impossible. But we could do, I think, more of what is being done in Massachusetts and Rhode Island and Connecticut, which is we're going to grow this pie only at the rate that the economy grows and aging of the population. And if you're asking for more, so let's call out a hospital system, and you're asking, the economy is growing at 2.2%, and you're going to ask for a 4.9% increase, we're going to call that out. And we're not going to approve that if you're a state regulator or some other mechanism to prevent that from, rising. And there is no law of nature that says healthcare has to increase faster than the rate underlying growth of the economy. And we know that has adverse consequences when healthcare takes so much, 18% of GDP. It's taking money from other worthy services, typically things like education, environmental work, infrastructure investment. And I think we should have healthcare stay at 18%, go no higher, and that'll be a big, big boon to the economy, actually, if that happens. And I think one of the reasons we saw in the 2010s actual robust growth in the economy is healthcare was projected to go over 20%, and it has stayed under 18%. It's one of these mysteries of why that happens. I have my own theory that I've publicized. I'm not necessarily popular with all my colleagues. But the fact is that healthcare has remained.
What's the theory that's made you unpopular?
Well, I think that the alternative payment models, that putting in and emphasizing cost and the alternative payment models has made doctors redo how they deliver care and actually brought it down.
Yeah.
Or at least not let it increase. It didn't come down, not let it increase.
So we have a bunch of good questions from the audience. Before we get to them, I'm going to do a lightning round with you very quickly. I'm going to name a country, and I want a one-word answer for the idea that sort of stands out in your mind as an impression of that country. Try this. We'll see how this goes. So Germany.
Oh, well, there's unlimited choice and too many hospital beds. They have 40% more hospital beds per person than we do. And it's not only that they can't cut it, they won't cut it. The economy's doing so well, why take the pain of trying to cut hospital beds? So you do get this advantage of unlimited choice, and you have this sort of overgrown part of the system that everyone, including the Germans, recognizes a big problem.
Britain, Great Britain, UK.
They have, I think, some quite good ways of evaluating technology through their NICE program. They also have very good primary care, but it is also an example of a system that over years and years and years, you can starve it by underinvesting, and it can begin to fall apart. And I think they have underinvested by 1 or 2% a year. And if they just brought up their spending, 1 or 2%, not even, we're not talking about American levels, we're talking about, other Western European levels, they would have a fantastic system.
And we'll do Switzerland for last.
They're another country where people love the choice, people love the system, and recognize that it's hurtling towards the precipice of too much cost. I will tell you my favorite Swiss story, which is about mental health, which we haven't talked about at all. One of the things that we really focused in on our book was how are different countries dealing with the mental health issue. For 150 years, we have sort of hived off mental health, and not just us in the United States, but every country. It's, the hospitals are somewhere different. The notes are in a different notebook. The psychiatrists with everyone else don't interact. And so we went to Switzerland to try to find out about how they dealt with mental health issues. And the head of the health system in Geneva says, "Oh, mental health. Yes, 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 yes. The hospital, it's over there on the border with France near the prison." Everything you need to know about how they view mental health, right? If we could push it just over the border, that would be good.
Yeah.
And it's right near the criminals. What's the difference?
Yeah.
So, and there's also a lot of, Switzerland has one of the things is a little corruption. So every Swiss health insurance company has to be not for profit, but it can be affiliated with a for-profit. And how the money flows back and forth in Switzerland, like all money flows, hidden under a blanket of secrecy. And there's a lot of views that that's pretty corrupt. Also, every politician who gets on the federal health committee ends up on the board of an insurance company, insurance company.
So that happens over there too.
Oh yeah. In Switzerland, it's
Corruption
not pretty.
Corruption does not know national cultures or borders. Same everywhere.
When it comes to money, I think in Switzerland, there's a lot, there's a reason, you have bank accounts that no one can find out who has them, what their name is and how much money's in them.
Right.
Swiss bank accounts are there for a reason.
Right.
Well, it's deeply cultural.
Actually, one of the top questions vaguely related to that, so I'm going to ask you, this is from Liz McKenna. Why are healthcare facilities in the US not transparent about their pricing? From my experience, it's very difficult to get an accurate idea of how much procedures will cost. There's so many hidden costs, outsourced lab work, and you never know until you get the bill. Why is it so complicated, even before the health insurance industry gets involved?
Oh, no, it's because the health insurance industry is involved. It's because there is no such thing as the price. So this is actually one of the lessons we learned from the study we did. Every other country, there is a price. It's a price. So if you want to help poor people, you don't adjust the price and you have a Medicaid price and a Medicare price and a private insurance price. You adjust the price and then you supplement the poor people. One price for the whole country, supplement. We don't have that. We have multiple different prices. So there's a Medicare price, there's a Medicaid price, and then there's a price which is different for every different kind of insurance company. So you say, how come I can't figure out the price? Lots of insurance companies can't figure out the price either, and nor can your doctor. So part of the work I do now is to try to get doctors to use lower price facilities. So if they're a surgeon, go to hospital A or B or C or ambulatory surgery center D or E, go to the cheapest price where you can do it safely. Turns out they don't know the price either. And so they don't know that if you give up on hospital A and go to ambulatory surgery center E, it's a lot cheaper for the whole healthcare system. So prices are a problem. And one of the reasons we have all these prices and there's no such thing as the prices, because there really is no such thing as the price. We've created this crazy way of trying to save money that is really, it makes no sense. And it is irrational. And the same thing with drugs, by the way. There's no such thing as the drug price. There's a list price, but every different pharmacy has a different price depending on how much they buy, what package of drugs they take is preferred, etc.
Well, so next question from anonymous attendee is, what would you do to lower drug prices? So what,
do they work at the White House, by the way? Does Anonymous work at the White? Is that Anonymous?
WHO.eop.gov. No. But that's right. I want a huge idea, the greatest ever drug prices. No, just kidding. No, what I could imagine a call like this from the current president or possibly a Democratic alternative a couple of months from now. What do you do about drug prices?
So we did look at drugs throughout the world. And there's, again, lots of lessons you can draw from almost every country. First of all, almost every country uses some objective measure to set their drug prices. So they often look at, is the new drug therapeutically better than what's existing on the market, or is it the same? If it's the same as what's on the market, often its price will be capped at what those similar drugs are, or actually in some countries, they're forced to be 5% cheaper. If a new drug comes on the market, some countries say all drugs in that class need to lower their price. So they look at how much better therapeutically a drug is. They often look at it in terms of setting the price related to the health benefit. The more health benefit is, the bit higher the price. That's true in France, it's true in Britain, it's true in other countries. They review the prices every few years and ratchet them down. And by the way, this is true in Switzerland too, which has two big drug manufacturers, Roche and Novartis there. Some of the countries, France and Britain being the two leading examples, they have a total budget for drugs, and every year they indicate how much that budget could grow and limit the drug prices within that envelope. So you have a lot of different mechanisms. And let me just say one of my favorite. Drug price regulation doesn't have to be done by the government. In Germany, the negotiations on what the price will be. So the government evaluates whether the drug is therapeutically beneficial, if it's the same as existing drugs or is better than existing drugs. And then the price negotiation actually happens between the consortium of insurance companies and the drug manufacturer. If they can't come to agreement, it goes to binding arbitration. So the government doesn't have to be the negotiating agent, as we say. There's a lot we could learn. And by the way, I'll say that the three major bills that are have been in front of Congress, Pelosi's bill, Congressman Lloyd Doggett, and the bill out of the Finance Committee by Grassley and Senator, why am I blanking on his name? Ron Wyden out of Oregon. None of them actually are nearly as robust as most European countries. And again, one of the things you learn from all these countries is you don't regulate the drugs for people with chronic illness or the drugs for elderly different. It's all in one basket, and it's all going to be done the same, regardless of whether it's for Medicare patients or Medicaid patients or private insurance. One system.
There's a question from Shelley. Sorry, I'm trying to, where to go? I just had it in my window moved. Apologize. Oh, here it is. Diane, I apologize for potentially butchering this name, Diane Baudelaire. As a physician, I am daily astonished by the layers of bureaucracy that add nothing to patient care. Utilization review, prior authorization for so many procedures requiring even more administrators. How can we simplify our healthcare system and remove this wasteful overhead? And let me just press on that, which is it possible to simplify that without doing, something like Bernie Sanders wants to do and just blowing up the system? Is there a way to simplify it in the context of this patchwork?
Absolutely. So why do we have utilization review? Why is it out there? Well, we've learned that doctors often order tests or treatments that patients don't need, so-called unnecessary services, or they order services that are inefficiently delivered, that are delivered more expensively than at other places. And that's what utilization management and utilization review is all about. Because we can't trust your judgment, we're going to look over and get you to change it, and then you'll learn what is acceptable, what isn't. And I agree. There's no one who likes it. Doctors hate it, patients hate it, and it turns out if you actually ask and pick beneath the surface, insurance companies hate it, but they can't get rid of it because it saves them money. So how could we get rid of it? Well, we have to put the burden of spending and the judgment on doctors. They're the ones who know whether something's necessary or not, whether that added spending is worth it or not, and they have to take responsibility. So one of the things I've been doing for about the last 6 or so years is working on trying to change the payment system to doctors off of fee-for-service so that doctors have the amount of money and they make the judgment whether patients want it or not. There's no one looking over their shoulder with utilization review and saying, nope, can't do it, or no, you can't do it at that facility, you have to do it at this other facility. So I am totally sympathetic with you, but the way we're going to have to change that is to put more responsibility for the budget on doctors. And I think, we're now working with a large insurance company to try to get rid of utilization management for exactly this method. You do the right practices more than 90% of the time, we're getting rid of utilization management.
So there's another answer to that. I mean, I've heard it. I'm sure you've heard it. There's there's a kind of, I hear it from a lot of my free market enthusiast friends, which is, you're talking about working on the doctor's side, and they're saying, no, it should be on the patient side. If patients just could shop around, an example often cited is LASIK surgery, which the price has come down very quickly. I know I was recently reading a book by the recently retired Speaker of the House, former Speaker of the House, Paul Ryan, who wrote about healthcare in his book and talked about, hey, LASIK surgery, it's a free market. There's no regulation. Insurance companies aren't in the middle of it. Price has come way down. Quality is good. Can't we do that for all of healthcare? Doctor.
You want me to answer?
Yes.
Yeah. I mean, the best estimates are that would be true for 40% of healthcare. But let's say you got cancer, you're not really shopping around on the basis of price. You have a heart attack, what are you going to say? Oh, well, let's see which hospital has got cheaper cabbage surgery here. It just doesn't work that way for the big ticket items. And it doesn't work that way for the things that really, really matter. LASIK surgery is a classic elective procedure. You don't need it. You can have glasses instead. You have other options. So I think it is it's not the characteristic of what we use most of healthcare for. And by the way, where we spend most of our money. And remember, 85% of every spend is by someone with a chronic illness. And those people with chronic illnesses, they need help every day. And what we really need to be doing is not having them shop around. We already, as your previous question about the prices suggested, we're already driven crazy about shopping around. We just want to go to the doctor, get what we need. And it's that little thing, what we need. It's the doctors who really need to be responsible for that and need to be the ones who determine that. And we have to make them responsible. Right now, they just order things and someone else pays. And when the other person thinks it's not necessary, that's when we have utilization management and the whole annoying circle. I agree. It's an administrative nightmare. It's a frustration to everyone involved. We got to get rid of it. But we're not going to get rid of it just by waving a magic wand and giving patients more financial responsibility. We already know that consequence. They're groaning under the deductibles. We need to get doctors more into the driver's seat.
An interesting question from audience member Robert Goldman. Which healthcare systems do better with regard specifically to patient safety? Steve Burrow in his documentary Bleed Out tells the story of his own mother who nearly died after hip surgery. In general, what did you find about safety and quality and how that varied, and who's doing a good job of that, and who isn't? Is anybody doing a good job on that?
Well, first of all, we didn't specifically focus on that, but it is the case that you actually hear a lot of the same complaints in a lot of the other countries. And interestingly, if you go to Australia, no data, no comparative data, no. One of the big frustrations we heard over and over from the doctors there is we have no idea how well we're doing, how badly we're doing. We don't actually collect that. We don't systematically have, the kind of health services research we have in the United States that show us where we're doing well and where we're doing poorly. On the other hand, a lot of things that are easily controlled by doctors, like infant mortality and maternal mortality, we do in the United States particularly badly, and other countries do much, much better. Every country we looked at does better on those, as an example, on those two metrics. But I think one of the things we know, again, we found is that the United States, partially because we do badly in many of these things, we have innovated in them. And, the best places we have shown you that you can get, say, surgical site infections down to near zero if you really are concerted and look at it and track them and really, have a concerted effort to look at the processes and eliminate them. Our problem is we have not incentivized people to look at the processes and eliminate them in a systematic way. It's still easier for places to make more money by what we call upcoding, saying patients are sicker and collecting more money from the insurers and Medicare on that basis.
I'm going to ask you upon your political hat, which is not your normal hat, but you're in this world, so maybe you have some thoughts. This is a question from audience member JR. I'm going to paraphrase it a bit, but basically, how do you get to how do you move our system in the direction of some of these other systems without getting the socialist label thrown at you? Or do we, should we just not be afraid of the socialist label at this point? I mean, I don't know. My kids don't seem to be fazed by it the way my parents were, so maybe it's, less an issue.
They didn't live through Joe McCarthy. I think one of my views about this is that we start out with the government programs and we really push hard on the government program. So with my brother, we wrote an article about, we're never going to expand Medicaid. There's no blandishment you seem to be able to give to Texas or Florida or Georgia or North Carolina that's going to get them to adopt Medicaid. If we want to get to, and by the way, without Medicaid expansion, there is no path to universal coverage. Simply cannot happen. And if we're therefore going to get to universal coverage on some of the structure of the existing system, you got to nationalize Medicaid. Is that socialistic? The government's already paying, whether it's state government or federal, but it's already. So there's no change in the government involvement. And then it seems to me that you can somehow merge Medicaid with the exchanges, and that will simplify the system, also give you a lot more heft in terms of changing the system, in terms of payment to doctors, payment to hospitals. And I think that's how we move our system. Simplify it, get one set of prices, and by the way, I would move all the prices to Medicare prices, one uniform set of Medicare prices.
Medicare or Medicare plus a little bit?
I would stick at Medicare. I think Medicare is
hardcore.
Is fine. Yeah. And then, there are various other things I would put in, but I think then you're really beginning to move towards a simpler system, more uniform pricing in the system. And I would pay in each one of those categories, pay the doctors differently. And that will, I think, get you more towards the direction we want. And as I mentioned, zero copays for primary care, zero copays for generics. And you're beginning to push into a system that I think is much more rational and much better for patients.
We have like a minute and a half left. So you're going to I'm going to ask you for your prediction. Where you think, let's assume, let's pretend that Joe Biden wins the presidential election, Democrats get majorities in Congress. There's not a judgment on Democrats or Republicans, but they do seem more interested in healthcare reform at this point. What do you expect them to try to do early? Or what would you like them to do early? I mean, I don't care. You can answer it either way.
I think one thing that is quite clear is that drug pricing and affordability is a topic. You've got an affordability problem. You also have this problem of coverage. Tens of millions of people have lost employer-sponsored insurance, whether because they're a worker that no longer gets it or they're a dependent on a worker who has lost their job. We've had an estimated increase of the uninsured by 5.4 million. That's a nearly 2 percentage point rise. I think you are going to have an expanded coverage and drug prices. I think those two things are pretty imperative. To pay for the expanded coverage, I think you're going to need some of this cost control through alternative payment models. So I think that's the triple crown, as it were, that you have to adopt, and you have to do it all at the same time. So I think that's the direction that I would look to have things move.
Well, maybe that's where we'll have to wait and see. Well, Zeke, thank you very much. I know we're coming up right on the 9 o'clock hour here, or 9 o'clock hour in the East, as they say, 6 o'clock out West for those of you in Powell's land. But I just want to thank you. This was a lot of fun, and I hope people will get the book because it is fascinating and a resource you can use to argue at the coffee, at a family gathering, but also something to make you intelligent as you sort of follow this debate that's unfolding. So thank you. Stay healthy, keep doing all the great work, and thanks to Powell's for having us.
Well, thank you so much.
Thank you, Jonathan. As usual, fantastic interview.
That was wonderful. It was a pleasure to host both of you and to welcome everyone out there in the audience. Please do consider purchasing a copy of the book on powells.com, and we hope to see you at another event soon. Until then, take care.